Well, I'm John Snyder. Thank you so much for this opportunity to share our story about what we're doing in integrating care. I went about it backwards. You know, I said, well, how are we going to integrate primary care in the dental setting rather than let's integrate primary dentistry in the primary care setting. So I kind of went around it backwards. So it'll make more sense because we ran into the same problems you heard earlier, where we would go to primary care physician. I'm too busy. How can I ever do any of those things? I don't have enough time with all the other things that I have to be doing, and I just don't have time to that. So I thought, well, let's come in, let's show up as help. Let's show us up as help, and let's work on integrating certain elements of the care that have the impact on the physician group. What would those be? They'd be HEDIS measures because they get paid on those. And so if I could help improve their HEDIS scores, would that then give me some leverage that I can use in getting dentistry integrated into primary care? So the fluoride varnishes you heard. And so that's our story. So this is who we're about. Permanente dentistry is ethical, evidence-based, integrated with a relentless pursuit of quality and patient safety. And I'll talk about each of those elements of how we're trying to advance this philosophy of care with a large focus on integrated care. Because I think we're just uniquely positioned in healthcare now. We're the only ones that have like an hour-long visit with our patients anymore, and we got them pretty much captive. So we can do a lot around really being that extender of primary care, that message of prevention. But this is who we are. And it's really what makes us so unique is we have a vertically integrated system. I have a health insurance company that surrounds me. I have a physician group. I have all the other healthcare workforce in place. And all we're doing is adding a toothbrush to these and expanding that team in the vertical integrated model. And all those are important. And so I'm the Executive Director and Chief Executive Officer of Permanente Dental Associates. This is how we're related to Kaiser Permanente. Kaiser Permanente is not an entity. It's a brand name. We provide the P, they provide the K. Kaiser Foundation Health Plan of the Northwest, a nonprofit, 501c3 corporation, has a contractual agreement with this professional group, a for-profit professional group, Permanente Dental Associates. And what we do is I enter in each year into a negotiation with the health plan, and what I get out of that is a global payment per member per month. So when we were talking earlier about, well, how do you make all the finances work? I have a mechanism of how I can make the finance work because I got a global payment, and I can do a lot of stuff with that. And this is who we are. We have about 170 dentists, 21 offices, see about 287,000 patients. We're right in the beautiful Willamette Valley of the Northwest. That's where about 70% of the people live. Most of Oregon and Washington, unbeknownst to most people, is desert. Only that area in the Willamette Valley where all the agriculture is where most of the population lives there. So our journey in integration, it's kind of fun because we started doing blood pressures way back in the day, and people were like, well, what are you taking a blood pressure on me for? This is a dental visit. That's how far we've come, really, in this journey of integration. We did some really interesting things around, came up with this idea for tobacco cessation. I can't teach everybody, all the dentists, how to do the 5 A's of tobacco cessation, but what I can do is I can get them to do part of that. And so that was our first kind of idea of looking at different workforce models and how do we leverage the existing expertise within the medical setting so that I don't have to train up a bunch of people to be really good tobacco counselors. I can't afford to do that, and I can't sustain it over time. So we've been on this journey, and now we're really dealing with what's our workforce models into the future. And that's what we'll publish on. So we have these advice slips. Everything was paper-based. So we had these advice slip. We take the blood pressure if they need it. We give them this advice, and hopefully they would go see their physician. Hopefully that story of the referral that was shared at Marshfield, you'd hope that they would get this follow-up. But we followed evidence-based guidelines, American Heart Association guidelines. We did ask, advise, and assess, which are 3 of the elements of the evidence-based tobacco cessation approach. So ask, do you smoke? It's bad for your teeth and gums. Hey, are you thinking about quitting in the next 30 days? That's all we had to do. And then we get them using old technology, the landline. We would get them on the hot red phone to call and talk to a tobacco cessation specialist if they were willing to consider that. So that was what we were doing. Dan, this was the big game changer. And you saw it on Marshfield's on there, the care gap report. So what we started doing is because we have our 90% of my patients have medical and dental insurance. They have the same insurance, Kaiser insurance, all right? So same health record number. So we could start getting information printed off on our patients that were coming into the dental setting if they had any care gaps. And so we got this care gap report. And these care gaps link to HEDIS measures, which is a mechanism of reimbursement. I think dentistry is about 20 years behind medicine. We're just talking about value-based reimbursement. We're talking about care team approaches, the dental home, all that. So we could really leverage this expertise. And so we got these care gap reports. And these are just patient-friendly reports that are written up so the patient can understand exactly what the care their physician is recommending for them to receive. And so we started out literally like, hey, your physician knew you were going to be in today. I'm just a dentist. You have some care gaps. You need to go follow up on those. That was our conversation. Because I kind of teased the dentist in our group. I said, if you want to be called doctor, well, you better engage in the healthcare system. This was our journey to engage in the healthcare system. And it was easy. It's a patient-friendly. We can read this and say, oh, you have to get your blood test for your hemoglobin A1C. You got to get your retinopathy test. Those were the things that we slowly introduced that into play. And so this is kind of the results. This is kind of an interesting one. So interesting. I have 2 slides of the same slide I found this morning. But anyway, so what we said, we got 9,000 diabetics, okay? At the start of the year, we identified 9,000 diabetics. And we said, well, what has been the care gap closure to get your eyes checked, get a urinalysis, and get your hemoglobin A1C on an annual basis? What's the medical program been doing? So for the last 5 years, they hadn't budged this at all. It was like 54% is what they were getting diabetics. 54% of the diabetics were getting their care gap closed. And we said, well, wait a minute. We're really good at the care gap closure. We've already proven that we're one of the top departments of all departments. The only people that beat us are nurse treatment and family medicine. Dental was the 3rd leader in getting people to close care gaps. Pretty impressive. I think we're genetically engineered to close care gaps because our whole education is based on preventing disease, so we can be really good at it. And so we're winning on this one. We got 60% now of the diabetics of that 9,000 population that started at the beginning of the year. We got about 60% of closed care gaps now. And if you look at that, if you just had a dental visit, last week, no medical visit, you had a 65% chance you were going to get your care gap closed. If you had a medical visit, no dental visit that last week, you had a 55% chance you're going to close it. So 18% improvement in the closure rate of that. And there's a reason for that, but that's the very last slide. And then the big game changer. December 15th, 2016, we went live with a fully integrated electronic health record system, Epic. Epic created Wisdom, a real clever name for a dental module that fits on top of the ambulatory care platform. So we have all the interfaces are all in place like pharmacy. So we write prescriptions just like any doctor would. And that's all integrated in the system. Huge game changer. We don't even know the full capability. But, I was talking about care gaps and everything before, and I think I'll talk come back to that because I have that. Now we have best practice advisories. You remember that little sheet of paper we did for blood pressures? Now this pops up, tells me what I need to do, and I got to interact with it in some manner, like click OK, that I'm going to do all these things, and that populates my record that I've actually done it. So we can start tracking who's really engaging and doing the advancing the integration. But now it's all changing. Now it's changing around. How are we going to reimagine the dental home? Who's going to be part of that care team into the future? If I'm moving primary care into the dental setting, who's going to be part of that team? Given all the regulatory complexities that we have in Oregon, in states, Oregon's different than Washington, the state right across, which is different than California. So what do we need to do in reimagining the care team? And so we, in 2016, we opened our first dental and medical office. So I have there's a physician who has 3 exam rooms at this end of the hall. And then we have the dental practice, general dentistry, and pediatric dentistry. So we look at pediatric dentistry as primary care. So in our offices, we generally have pediatrics in all offices. But this is the first one, and pretty amazing compared to, I said we had 21 offices. Compared to our other co-located offices. So we have about half of the 21 offices are in the health center or right across the parking lot. So you have the medical office, dental office, parking lot. So that adjacency is there. But they just were knocking it out of the park with what they were doing there, and the ability to, compare to these co-located facilities when there's a dental just in the facility, they really did amazing. And that's part of the cultural transformation that changes when you get adjacency and interprofessional interactions. You can get some amazing results. Everyone was bought into that. And now we're testing 3 different models now where we have LPN nurses, licensed practical nurses in the dental setting. So in 2 of them, we have LPNs in the dental setting, and we're testing those models, what we can really do. And then it's in one of our co-located offices, but we made sure everybody absolutely knew in that office where the new nurse treatment center was so that they could walk those patients down to the nurse treatment to get their blood draws or whatever, their immunizations taken care of in that setting. And we're testing all these. And why are we doing that? We're looking for the most affordable models, but also that gain the most efficiency and improve outcomes, like HEDIS scores. So we're doing both. So we're testing workforce models in that. We're doing. This was just MAs. We looked at. So this is when I said we don't even know the value of that electronic record system. Okay, we knew in this for 2 weeks during the flu season. What we did is we found everybody that was 65 years old, hadn't had their influenza vaccine the previous year, and I knew that because of the health record system. They didn't have it. And we said, how many of those can we get to get a vaccine? Because I know what office they're coming into, who they're seeing, and what time they're going to be there. And so I can get information shipped to those dental offices saying, you have a 65-year-old, non-compliant individual that didn't get their vaccine last year. See if you can get them to do that vaccine. And in our LPN offices, they get the vaccine right there rather than go down the hall. In this case, we provided a medical assistant that could provide the vaccinations at these 2 offices. And over 2 weeks, 200 flu shots. If I prevent one of those people from not having an inpatient services associated with the influenza respiratory infection, one of the 65 Medicare, I paid for that whole day, every vaccine, and then some. So we can do it effectively and efficiently. I think we can get better outcomes. This was one we just did, and it was broader. It was all age range, but we did it for 2 weeks, and we had about 744 vaccinations closed. And when I was talking about the care gap, closing care gaps, one of the mean tricks we do is what we do is we look at all the people that are sitting out in the waiting room, and we find out if they have any care gaps. So when the brother or sister goes back to see the pediatric dentist and they're making fun of them that you're going to see the dentist and getting shots, we grab them and say, how about you come back with us? We're going to give you your vaccination today. So not so funny now, is it? So, but we have the information. We have the information in that system that allows us then to do focused approaches like that. And I think it's going to be great because what did I want? What did I want in all this? I wanted 2 care gaps, oral health care gaps that the physicians see. I wanted the physicians to see those. Now, I helped you get higher HEDIS measures. Now, you got to help me now. And then I can get the buy-in from the physicians that they're not so darn busy anymore to help me out. Because we've demonstrated we're busy too, but we're doing a good job helping you get more highly compensated. But we introduced these 2, and you know it's obvious why we did this. We did diabetics, because we know the implications of diabetes on periodontal disease, and we did little kids because it costs a lot to take a little kid to the ASC if they get bottle mouth. So that's why we got those care gaps. And so this is why we can do a lot of what we're able to accomplish. I have a global payment system. So if you look at traditional, you fill a bunch of holes in teeth, submit those claims to the insurance company, and they pay you, all right? In our model, I negotiate the global payment. We as a professional group who should know and have the best understanding of what we value and what we should be measuring that improves the health of our patients, we figure what we value and we care about, what supports Permanente dentistry, ethical, evidence-based, integrated with relentless pursuit of quality and patient safety, and we measure that. And the way dentists get paid in our group is if you're doing those things. So if you think about integration, what we looked at is what's the patient's experience? What's the patient's experience of that integrated model? Because if they really like it, and they do because of what reason, not the one I was hoping for, it wasn't like, hey, we really value that I'm healthier or I'm better. Oh, no, it's so much more convenient. I don't have to drive here again. I can get my flu shot, get all this done. It's all around convenience. So what we look at the patient experience and then the diabetic measure. So here we are, and you can see this is good QI. You see step-ups as we've changed processes or done something, and you step up, and this is top box scores. These are like very good only scores, and we're up at 70, I think it's 74.4 the last one, 73 on average, which is the highest it's ever been in our group's history. So the dentists get paid on that. If your office got really high press Ganey patient satisfaction results on the dental team's care for your overall health, you got paid more. And the same thing with this diabetic measure. We're at 63%, doing great on this measure. These are all the offices along the bottom. Everybody's kind of engaged. And because we went above our target that we negotiated in the MOU, the dentists will be paid more because we did a good job about diabetics. So it's that value-based reimbursement model. I think I have a summary slide here. And I think this is really important. Provide an integrated, this is really our vision around medical dental integration, provide an integrated medical and dental experience that is a new standard for high quality, convenient, and affordable health care. That's what it's about. And you know why? What the cultural shift we made finally now from going from the care gap report at arm's length to taking a shared responsibility for our patients' total health and wellness. That's the evolution of our group. That's not universal across every dentist in PDA, but I got momentum. So I'm winning on that one. And really what it is, it's having this shared total health philosophy. It's having a shared population of patients. It's really the co-location of facilities. I thought technology would solve that, but it really comes down to convenience. And so that's not going to be solved. It's the shared informatics platform and it's global payment. All those things are fundamental and essential elements if you truly want to integrate care. And it's fun. So thank you so much. Appreciate it.